Okay, so good evening, everyone, and welcome to today's webinar on osteoarthritis. Can it be prevented? So today is a super exciting session. We are incredibly fortunate to be joined by one of the world's foremost experts in osteoarthritis, Professor David Hunter. Just before we dive in, I will do a few quick housekeeping notes just to make sure everyone has the best experience today. And so I will remind everyone to keep things running smoothly. We kindly ask that you keep your microphones on mute during this session. I'll do my best to help out with that in case you can't find where the mute button is. We'd also love to hear from you. So make sure that if you have questions, I will ask you to post them into the Q&A box at the very bottom of your toolbar. I will definitely be circling back to those and get to as many as we can during the Q&A session at the very end. And I will actually remind everyone, you don't have to worry about taking notes on everything. This session is being recorded, so we will send you the replay along with some useful resources and links afterwards. So that's it for housekeeping. Now I do want to get started today and just remind everyone that this is truly an honor to have Professor Hunter here with us this evening. He is a highly respected rheumatologist, clinician, and researcher whose work focuses on advancing both clinical and translational research in osteoarthritis. He is recognized as the leading expert on osteoarthritis by ExpertScape, and he serves as the section editor for UpToDate on osteoarthritis, the editor-in-chief, Osteoarthritis and Cartilage, and he hosts the Joint Action podcast as well, which I'll be linking you all to at the very end of this session. He has hundreds and hundreds of publications in peer-reviewed journals, and his contributions to this field are unmatched. So as the leader of the osteoarthritis team at the Kolling Institute, Professor Hunter is dedicated to improving our understanding of this disease, as well as enhancing the quality of life of those affected. So please join me in welcoming Professor David Hunter, and I'll hand over to you, Professor Hunter.
Thanks so much, Mary. It's a great pleasure to be back, and thank you very much to the arthritis movement for the privilege to spare a little bit of time with you this evening. And thank you all very much for joining in. I guess firstly, it's late in the evening, well, depending upon where you are in the world, but 6 p.m. here my time. There's going to be a lot of links that I share in my slides. As Mary said, she will send out the recording. I will also send Mary the slides so she can share those with you. If you do miss something, don't worry. I will try to go slowly through some of these slides at different intervals so that those links are available and accessible to you. But while an hour probably seems like a long time in your life to be digesting information about osteoarthritis, there's a lot more that's out there. And so I can't cover it all within an hour. And so that's why I provide a lot of links so that you can hopefully tap into some of the resources that'll help you with both information about the disease, but probably more importantly, how you best self-manage. And so that's really going to be the key today. I will be, hopefully, as I said, providing a lot of information to you. And please feel free, if there's something that I do say that makes absolutely no sense, please do ask me about it.
Is this going to be recorded?
Yes, yeah, it's being recorded.
And will I be able to send the link because I can't make it today?
Yes, you'll be able to send you'll receive the link and you'll be able to send it to others. Yep.
So will I be able to see the whole presentation what you're having today?
Yes, yeah.
So if I miss it out today, is it okay?
Yep.
Because I can't make it today.
No, that's fine. That's fine. Yeah. I guess firstly, just by way of introduction to my declarations, most of my funding comes from the National Health and Medical Research Council in Australia and Arthritis Australia.
So when will I get the link?
As Mary said at the outset.
Yes, sorry, you will receive the link and you don't have to worry about missing out on the session. It will be available in the recording, and give us an email if you have any questions after that.
Okay, so will I get the link by tomorrow?
Yes, as we previously stated. We'll mute you right now. Over to you, David Hunter.
Thank you. And I obviously also do work for Osteoarthritis and Cartilage, UpToDate, and also receive funding from the National Institute of Health. I would also like to acknowledge the traditional custodians of the land and pay my respects to elders past, present, and emerging. This is an outline of what I'm going to go through this evening. I'm going to talk, at least in the first instance, about what osteoarthritis is and the burden of disease, and then look at some of the different research priorities that we could be pursuing, and I guess highlight some of the studies that we're currently doing, and hopefully those might be of interest to some of you as well. Look at ways that we can improve the care that you receive, and then try to be a little bit futuristic. So where are we heading with regards treatments, and what difference hopefully will that make? And then I think most importantly, open it up for your questions, because obviously that's key and critical to hopefully improving your understanding about this very prevalent disabling disease. Now, this is just an example slide, but it's really just to show you, for most of the slides that I do want to focus on and hopefully draw you towards, there'll typically be a QR code and, where appropriate, a website. Okay, I'm going to show you this slide again towards the end, so please don't feel free that you need to get this right now. But for those of you who are unfamiliar with using a QR code, by all means use the website. This particular website takes you to our clinical trial page, but again, I will show you this particular slide later, so don't feel that you need to get that QR code right now. And again, I will try and spend a little bit more time on those slides that do have a QR code, just in case you want to capture it. All right, now firstly, osteoarthritis is a disease that can affect any of the joint tissues, including bone, the lining of the joint, what we call the synovium, the ligaments, the muscles. And in addition, it can also affect the cartilage, but it's a disease of the whole joint, meaning any of the joint tissues can be affected. And typically, by the time a person presents to clinical care, multiple joint tissues are affected. But it's more important what you experience. So that's the disease, but the illness is what we call the lived experience. So that's the pain, the loss of function that can emerge as a consequence of you developing osteoarthritis. And it's really important for you to understand that the relationship between the structural change and your symptoms, at least according to studies where we've done x-rays and looked at the relationship of that to pain, is not strong. So just because you have a bad x-ray doesn't mean you're going to have bad pain related to that. And the converse is also true. This is an incredibly common problem. About 3 million Australians, about 600 million people around the world have osteoarthritis. And by virtue of both increasing aging and increasing risk factors, particularly people being above a healthy weight and joint injuries, we're seeing a lot more of it. So again, about 600 million people around the world, largely because of joint replacements. It's the second most costly health condition treated in hospital. And because of its large impact, it's about the 11th highest contributor to global disability. So it has an enormous impact. You're all here. I probably don't need to advertise that fact to you, because you're all probably experiencing this. But it's in that context where we know that there are also huge unmet needs in terms of pain. And oftentimes the treatments that we advocate for have small effects, and quite frequently the pharmacologic management has toxicities that are associated with that. And our health system is a little bit counterintuitive. So they often pay for volume, and there I'm particularly thinking about things like arthroscopy, MRI, which we know are of not great value, but they don't pay for the quality of the care that you receive. And in an ideal world, those two things would be inextricably linked. So ideally, we would pay much more for the quality of the care that you receive and the outcomes that you receive from the care that you receive, rather than necessarily based upon the number of procedures that a particular person does. Now, I'm going to go back a little bit into ancient history. And you probably know the chap on the left. His name is Charles Darwin. And he came up with the theory of evolution, which proposed that we evolved from essentially apes, or the simian. Now, one important difference between us and apes is that we do have what's called an opposable thumb. So we have the ability to do things with our hands, like grip the remote control. But that mobility has also increased our risk or susceptibility to develop osteoarthritis in the base of the thumb. And for anybody who has that, you will know that it can be markedly disabling as it relates to performing things like grip strength. So, opening a door, opening a jar, or things of that nature. So again, we've evolved, but I guess quite interestingly to me, over the last 100 years, we've evolved even further. And so if we look at skeletal remains of skeletons from the early industrial phase to the post-industrial phase, the number of people who are developing osteoarthritis has more than doubled. And that's even after you adjust for body weight, sex, and ethnicity. So, what's happening that's changed so dramatically, basically in the last 100 years, that's led to a doubling of the people that have osteoarthritis? Could it be the shoes that we wear? And so this is one of my postdocs, Anosha Atharakula, who's based in Colombo, Sri Lanka. And more recently, she's done studies where she's looking at bare feet and the role that they play in potentially preventing the development of symptoms related to knee osteoarthritis. Obviously, a study it would be pretty hard for us to do in Australia, but bare feet is quite common in Sri Lanka, and it appears to be protective as far as the development of pain is concerned in the context of knee osteoarthritis. Another potential theory that's changed over the last 100 years are the changes that have occurred in what we call our built environment. So the pavements upon which we walk, our ability to access green space, our access to healthy food alternatives has changed dramatically. And this is an area that, again, another of my postdocs, Jocelyn Bowden, is very interested in, is looking specifically at the role of what we call the built environment as it predisposes towards osteoarthritis. Another big change is our access to processed foods. I mean, we know that the microbiome, the gut flora, if you call it that, plays a really important role in predisposing to osteoarthritis, and the immune system that changes that co-occur with that are really important in the onset of disease. And we know that similarly, highly processed foods and the Western diet, which is sort of rich in calories, low in nutritional benefit, and high in saturated animal fats, and low in particular aspects of goodness, is not really good for our gut flora. So again, it's another area we're keenly pursuing with an effort to see if we can find ways to prevent the disease. And so when we look at the way we could handle disease, ideally, we would target those risk factors which we know are responsible for most of the reason why people develop osteoarthritis. Similarly, we would probably also target those people who are at risk of their disease progressing and do what we call disease modification. I'll come back again a little bit to that later on. By and large, this is what we do. So we palliate people. We give them painkillers, and when that doesn't work, we replace the joints. In an ideal world, we do much more of this, and I'm going to touch upon both of those and a little bit more in this presentation. So this is a complicated pie chart, but essentially looks at this concept of population attributable risk. So what's the proportion of people who are developing, in this instance, knee osteoarthritis, attributable to certain risk factors? So what we can see is about 45% of a person's risk of developing osteoarthritis of the knee relates to them being above a healthy weight. About 20% of it relates to previous injuries. Both of these are eminently modifiable, and both of them, at least from a public health perspective, we do very little about. So we could make a massive difference to osteoarthritis if we intervened to prevent these. Why are we becoming increasingly obese? So why is the proportion of people who are above a healthy weight going up so dramatically? Well, one of the key things is that the proportion of time that we spend being sedentary, so essentially seated or motionless, is going up quite dramatically. So even over the last 2 decades and projected forward, we see the proportion of time that we're actually spending in this sedentary time in terms of hours per week is going up quite dramatically and exceeds pretty much all of the other types of activity, whether that be leisure, domestic, or occupational. So in an ideal world, we would encourage people out there in the general community to be more active. Now, you might ascribe to this philosophy, and if you do, that's great. But in an ideal world, ideally, you'd balance that out with an appropriate level of physical activity as well. In addition to reducing physical activity, we're also seeing increased intake of oftentimes calorie-dense processed foods. I mean, so in a world where we're seeing increased caloric intake, and that is pretty much throughout the world where we're seeing increased calories over the last 3 to 4 generations, with reduced expenditure, we're likely to see increasing numbers of people that are above a healthy weight. And so not surprisingly, as a consequence of this, the proportion of people who are overweight is now about 2/3 of our population. And you might say, well, gosh, we're not that much better than the US. And that's very accurate based upon these weight statistics. So again, about 2/3 of our community are above a healthy weight. And again, that's largely by virtue of increasing sedentary time and increased caloric intake. Now, there's lots of different forces that are going on in our world that may be contributing to that. But similarly, there's a lot that you can do about preventing osteoarthritis. And that's the focus of one of our studies at the moment called the Osteoarthritis Prevention Study. So at the moment, we're recruiting women over 50 whose body mass index is above 30. So that puts them in the obese category, who live in Sydney with little to no knee pain in one knee, who want to be part of a community that's happy to be part of a 48-month healthy lifestyle program. So if you fit those descriptors, please, by all means, scan the QR code that we've got listed there on the slide. That'll take you to a site that provides more information about the trial and an opportunity to screen for that particular trial. So again, you will get these slides later. If you miss this particular link, don't worry too much. We will see it again a little bit later on. All right, that's an opportunity to prevent the disease. Now, if you have disease, bear in mind that for the vast majority of people, unfortunately at the moment, you're not necessarily getting the best care from our healthcare system. So there's lots and lots of different ways that we can improve that. But in the first instance, I think it's important that we reflect upon the fact that the majority of people who have osteoarthritis are not getting appropriate care, particularly when we compare this with a range of other common diseases that we see in the general community. So about 60% of people don't get appropriate care. What do I mean by that? Well, we're seeing a lot of MRIs, which are not helpful in the context of osteoarthritis because they drive up rates of unnecessary surgery. This is a disease that can be diagnosed clinically. We don't need MRIs to make that diagnosis. About 20% of people who have osteoarthritis are on long-term opiates. Most guidelines for care of people that have osteoarthritis recommend strongly against opiates, primarily because the harms outweigh the benefits. One of the most common orthopedic surgery procedure performed for osteoarthritis of the knee is that of an arthroscopy. Again, most guidelines recommend strongly against its use because most people who have osteoarthritis will get just as good outcomes if they had a sham arthroscopy. So that's basically a pretend arthroscopy without the cost, without the associated harm. So there's lots and lots of what we call too much medicine that's creating problems for our healthcare system in terms of both your outcomes, but also in terms of expenditure. So what should we be doing for people living with osteoarthritis? This is the College of General Practitioners guidelines. When we brought this out, we were advocating for people to be assessed holistically, to have that clinical diagnosis, meaning we don't need imaging to make this diagnosis, and then have an individually tailored plan for you managing your disease. Usually that's going to consist ideally of those things that are here in green, focused on educating you about the disease and how you can self-manage, talking to you about weight loss for those who are above a healthy weight, exercise and physical activity, and they are the core treatments for osteoarthritis. In addition, we'd advocate for review of medications, mood and sleep management, using topical medications, and where needed, walking aids and assistive devices. We see a lot of things that are in red, and these are things that are recommended against in the context of guidelines. So please bear that in mind. If you're exposed to these, typically they're recommended against in most guidelines for people managing their osteoarthritis. Ideally, this is what we're trying to advocate for, is these what we call osteoarthritis management programs. So they usually consist of those core treatments of physical activity and exercise, weight management, and education. They're evidence-based, they're proven to work, they're cost-effective, and they reduce joint replacement requirement. And they're available in a variety of delivery methods. And so we're very lucky in New South Wales to have the Osteoarthritis Chronic Care Program. But in addition, there's a range of other programs, including GLAD, Better Knee, Better Me, the Partner Program, and that delivered by Ramsay Connect. The big challenge, and I'm sure this is no mystery to you, is that, and this is where I was saying before about the health system being a bit counterintuitive, we pay for expensive items that don't work. There specifically, I'm talking about arthroscopy and MRI and don't provide a benefit for care. But for these things that we know do provide a benefit, they're not adequately reimbursed by Medicare. And you know for a fact that if you've got your 5 allied healthcare visits, that's all that Medicare is going to support you through for a 1-year period. So we're doing a lot in the advocacy space, trying to work with governments to change those policies. So please watch this space. But again, in an ideal world, this is what we would do for managing the disease. We try to tailor this according to individuals. We know that the presentation of your symptoms, the way that it manifests in your life, the impact that it has on you is unique to you as an individual. So ideally, we try and tailor this according to the way you present. And oftentimes we try to look to see specifically, in you, are your muscles weak? Is it your body weight? Is it your sedentariness, poor mood or sleep, the malalignment of your joint, overuse or temporary flare-up? For everybody, as mentioned before, we advocate for education and self-management, physical activity and therapeutic exercise, and maintaining a healthy weight. And then depending upon the manifestation in you, we then triage you towards other types of treatment, whether that be strengthening, weight loss combined with physical activity for those who are above a healthy weight, for those with poor mood or sleep, consider the role of cognitive behavioral therapy, and so on. So there's lots and lots of different options that ideally would be tailored according to the way you present when you're first assessed. Now, one of the areas that many people who have osteoarthritis are really interested in is the role of supplements. I think it's important to say at the outset, there's a lot of claims that are made in this space that don't necessarily have the evidence to support them, and are oftentimes false or misleading. Now, we know that historically, at least, there was a lot of interest in glucosamine or chondroitin, but based upon the existing evidence base, that interest is diminishing, largely because good trials have shown they're no better than a sugar pill. At the same time, fish or krill oil interest has increased, but not necessarily by virtue of good evidence to support its use in the context of osteoarthritis, primarily because of increasing interest in the community and the number of people who are going out and spending money on supplements for their osteoarthritis. We've set out to try to better the evidence base around this space. And this has been largely driven by Xiaochun Liu, who was one of my PhD students. She now works as a postdoc on my group. And this is work that she did during her PhD, where she started with what's called a systematic review. She then did a pharmacokinetic study, and we're now following that up with a randomized control trial. And I'm going to present a little bit of the data from that systematic review, hopefully in a way that's digestible for you. Now, this is a complicated slide, but essentially looks at a range of different supplements that are used in the context of osteoarthritis. And this is specifically a systematic review that we published a few years ago, when we're in the process of renewing that right at the minute. And what we identified is that a number of these specific ingredients had had more than one trial, and it had a positive effect associated with that. And so for those specific ingredients, specifically pycnogenol or marine pine bark extract, curcumin that you're probably familiar with, Boswellia serrata, and MSM, we've set about to combine those into one combination and test that in the context of a trial. Now, just to distill this information so it's a little bit more digestible for you, we set out and produced some what we call infographics. So those ingredients, again, that appeared to have a large effect in our systematic review were pycnogenol, Boswellia, and curcumin. In addition to MSM, they're the ones that we're packaging for the purposes of combining that in the context of a clinical trial. For those of you that are interested in participating in a clinical trial where we're testing that combination against a placebo, I'd encourage you all to enroll in what we call the Atlas study. So that's a QR code that'll take you to that particular trial. It's a 12-week online study, which means you can participate from wherever you are in Australia. And all you need to do to ascertain whether you're eligible for that particular study is scan that QR code to learn a little bit more about that trial. But if you're over 40, have moderate to severe pain, or have pain in your knee on both days in the last month, you might be eligible for that study. So that, again, that's the Atlas trial. You can scan that QR code and that'll take you to that particular trial. If you would prefer to just get access to that particular product, this is joint pain relief, which includes those 4 ingredients that we spoke about before in essentially the same concentration as we're testing out in the context of that trial. So that's Joint Action Care, producing the joint pain relief product. Again, that's the QR code that'll take you to that company's website, or alternatively, you can go along to their website to access that particular supplement. Again, it contains the same ingredients as we're doing the trial on. All right. Now, let's look a little bit into the future before we come to your questions. And again, this is my perspective on what the future might look like. And it's not necessarily limited to this particular space of research, but again, hopefully it'll provide you some solace that there's a lot of hopefully smart people working in this space to provide better treatments for you. What I'm going to focus on, at least briefly, is this whole area of what we call disease-modifying osteoarthritis drugs. So these drugs are designed not only to modify the symptoms that you experience from the disease, but also to modify the underlying structural changes that occur within the course of this disease. By and large, these will be injections which will be delivered into the joint with the hope that we can repair the joint tissues that are damaged or affected in the context of osteoarthritis. And by virtue of repairing those joint tissues, hopefully also relieve your symptoms that are associated with osteoarthritis. There's a whole range of different products that are being developed, targeting cartilage, some targeting the lining of the joint, which is typically inflamed in the context of osteoarthritis, what we call synovitis, some targeting bone. Some of these are in what we call phase 3 or late stage development for clinical trials, and at least one of those will read out in the early part of 2026 and go to regulators for approval, at least in the US at that point in time. We're doing a number of trials in this space, and I'm going to highlight one of those in a minute. But again, I think it's a really promising area that hopefully will lead to big changes in the way we manage people that have osteoarthritis. One of the things we're trying to do, mindful of the fact that your route to the development of osteoarthritis may be different to the person that's sitting next to you, is try to understand what we call phenotypes or subgroups. So we know that some people develop this as a context of their family history. Some people do so by virtue of having had an injury to their joint. Some people do so largely through what we call senescence or aging. A large proportion of people do so by virtue of metabolic changes. And here I'm particularly thinking about concomitant presence of the metabolic syndrome, so diabetes, high blood pressure, and carrying excess weight in parts of your body, particularly around the abdomen, which are not great for your health. So that accounts for a large proportion of the reason why people are developing osteoarthritis these days. It's much more common after the age of menopause, or after menopause rather. And mechanical overload can also play an important role. And more recently, we've changed this slide to also include inflammation. So all of these factors potentially can lead to the development of osteoarthritis. And we're trying to better understand that so that we can target treatment more appropriately, because there's a range of different treatments being developed to target different types of osteoarthritis in this disease-modifying space. Now, one of the treatments that we're trialing at the moment is a treatment called pentosan polysulfate. It's been used in humans for a number of years for a bladder disorder. It's also been used as a veterinary product for those of you that have animals, and it's called cartrophin, and it's quite effective in animals. We're now testing that in humans. It's a pill, and we're doing this in the context of what we call the MARVEL study. So if you're over the age of 40, have moderate to severe knee pain, you're not taking a medication to lower your cholesterol, and you can attend a number of study visits at Royal North Shore Hospital, this trial might be for you. So again, it's an oral medication called pentosan polysulfate. That QR code will take you to the website that will allow you to ascertain a little bit more information about the trial and where you might be able to go to screen for that particular study. In the interest of trying to get to your questions, because I think that'll probably be an area that hopefully I understand a little bit better what's important to you, I'm going to try and close out a little bit here. So firstly, osteoarthritis is a complex disease rather than just one single disease. So it's made up of a whole lot of different types of ways that it can manifest and a lot of different mechanisms that lead to that. As I said at the outset, it's extraordinarily prevalent and is a leading cause of disability in our community. As I said tonight too, prevention is possible and it requires behavioral change, but it's not something we're necessarily doing widely in the community. So again, just trying to promote the top study where we're trying to prevent the onset of disease. Ultimately, we need to tailor this to the individual because treating everybody who has the disease the same will likely just increase the risk of treatment failure. There's a number of different ways we can address this, both through preventing the disease, through public health changes, and also by providing appropriate lifestyle and behavioral change. And there I'm particularly thinking about those core treatments, educating you about the disease, getting you more active, getting you stronger, and maintaining a healthy weight. Those are the core treatments for osteoarthritis. And where needed, judicious use of surgery. Now, I'm really excited, as I should be. The future looks bright, but I think we need to be smarter about how we apply the wonderful treatments that are coming towards us in a much more patient-centered, personalized way. Just by way of a little bit of promotion of one of the activities we do, for those of you that enjoy listening to podcasts, we host every second week the Joint Action podcast, where we try to focus on topics that are immediately relevant to you. So again, it's the Joint Action podcast. We've got over 100 different episodes on a range of different topics that, again, hopefully are meaningful to you. This particular one is on supplements. This is from wonderful knee surgery group in Melbourne, focused on when and if you should have your joint replaced, the role of opiates. Matt Williams talking about exercise, should you have an arthroscopy? But again, about 100 different episodes. This week's episode that just dropped is on menopause, for those of you who particularly want to know about the role of menopause in the context of osteoarthritis. So that's the Joint Action podcast. Now, mindful of the fact that a lot of people don't want to listen to me and or don't like podcasts, there's a website you can go to. This is the Joint Action website. And so if you go along to the Joint Action website, it'll provide a whole lot of different information other than just the podcast. So what do you need to know about your osteoarthritis? What can you do about it? And so we go through those core treatments. Where can I go to get access to those core treatments? So it's got a lot of helpful resources in there. So again, that's jointaction.info, and that'll take you to the Joint Action website. In addition, we've recently revamped what was called the My Joint Pain website. It's now called the My OA website, and we're doing this with Arthritis Australia. And so that's about to be relaunched in an effort to try to, again, help disseminate information about how best you can get educated and self-manage about the disease. So again, that's the MyOA website, and hopefully it'll be a useful resource for you in terms of managing your osteoarthritis. Now, just in case you missed the links to the clinical trials, one more time. So this will take you to our clinical trial website, so osteoarthritisresearch.com.au, or scan the QR code, that'll take you there. And again, for those of you that have either missed that QR code or want to get it again later, I know Mary's going to send the recording out to you along with the slide, so you'll get that a little bit later on. I'd like to acknowledge the wonderful support I have from an amazing group of researchers that I have the privilege to work with at the University of Sydney, the Kolling Institute and Royal North Shore Hospital. So this is the team that I have the privilege to lead, who do all of the wonderful work while I have the privilege to go around and talk about it. I'd also like to acknowledge the funding that we get from a whole range of different resources that are listed there on the slide. I'm going to stop there and open it up for your questions. I've left plenty of time, and it looks like there's a number of questions that are popping up there in the chat. But if you haven't already had an opportunity to write something in the chat, please do so, and Mary will direct me to those. So again, I will say this hopefully again at the closing, but huge thanks to the arthritis movement and Mary for the opportunity to come back and speak with you this evening. I'm hoping the content was informative and helpful. And really happy to take your questions now, and hopefully some of those links to resources will be helpful for you again a little bit later on. So Mary, I'm going to stop sharing so that you can hopefully see the screen a little bit more clearly.
Sure thing. Thank you so much. Before I jump into questions, I want to personally thank you. That was incredibly presented, and it was very comprehensive, and I'm sure really useful to all the attendees here tonight. So it's really evident why you are the leading expert in this field of research. It's very evidence-based, and there's so much information available around self-management. Sometimes it's just about knowing where to go and where to find it. So having the direct links to that and the opportunities available to get involved with the research is very appreciated. So we have had all these influx of questions. And so in the interest of time, I will do my best to summarize them and try get straight into it. But we've had a few interesting ones in terms of prevention. So you've made it really clear that it is possible, it can be prevented. Is there any possibility of a cure?
Yeah, great question, and I think probably very near and dear to many people's hearts who are probably on this particular webinar. So one of the reasons why we're so focused on developing those disease-modifying therapies is that I do think that there's a real possibility in the not too distant future that we'll be able to use those treatments to help repair the joint tissues that are damaged in the context of osteoarthritis. So whilst many people might frame that joint replacement is a cure, all it's doing is replacing the lining of your joint. Typically, for most people that have lower limb osteoarthritis, so that's the knee or the hip, you'll have 2.7 joints that are affected. So that might be 2 knees and a hip or 2 hips and a knee. And so by replacing one, it doesn't cure the others. But by using some of the treatments that we're developing, particularly those disease-modifying therapies, I do think there is a real potential that we have the opportunity to fix the damage that's been done to those joints. Again, in the not too distant future, and again, at least one of our phase 3 trials will read out and go to at least the FDA, the US regulatory agency, in the early part of 2026. So it's not too far away.
Okay, excellent.
I'm happy to take that first one, Mary, if you want, about thumbs.
Yeah, I was actually just about to get into that. So about, why is it only knee pain? That's only really the focus of most of these trials and the research and where the treatments are essentially focused.
Yeah. So it's a great question, and I really appreciate that question. So that's why I wanted to dig into it. So we focus on osteoarthritis wherever you have that in the body. So both from a research and a clinical context, it doesn't really matter where you have osteoarthritis. We're interested in hopefully developing new treatments for it. Today, I've focused predominantly on the knee osteoarthritis trials that we're doing, primarily because they're the ones that we're recruiting for at the moment. We've done a number of different hand osteoarthritis trials in the past. And for you, I'm particularly going to focus on what I call the combo trial, so COMBO, which we published a couple of years ago in a prominent journal called JAMA, the Journal of the American Medical Association, where for people that had base of thumb osteoarthritis, we used a combination of a splint. So it was essentially a neoprene splint to support the base of the thumb, a topical anti-inflammatory, topical exercises to help with the movement and positional space of the thumb, and then what we call activity modification. And that combination was really quite effective at changing both pain and function for osteoarthritis. Now, you're going to say, well, that's great. How do I deploy that? And that's a great question. So one tip here would be, we did a podcast with a lady by the name of Margrethe Kloppenburg, so Kloppenburg, where she describes a little bit more about the treatments for hand osteoarthritis. But the other alternative for you more practically might be to go along to your local, what we call hand therapists. So that might be a physiotherapist or an occupational therapist that specializes in hands, to try to actually apply the results that we got in that combo trial. So please, we're not just recruiting for knee trials. We do intermittently, but albeit less frequently, do recruit for both hand and hip trials as well. So we're not neglecting you. There's a lot that you can do.
I guess the mechanical perspective of the disease makes sense when the hips and knees are affected by osteoarthritis. And so a lot of people here are now wondering about the inflammatory component of the disease. And so, you know, if you are in a higher BMI, can you speak a little bit more to that inflammatory component there?
Yeah, it's a really, really important area, and it's something that I think we're learning a lot more about, particularly over the last decade or so. And so we know that inflammation is pretty much germane in everybody that has osteoarthritis. So if we look, for example, locally within the joint, that what we call synovitis, so the inflammation of the synovium or the lining of the joint, is pretty much present in everybody that has osteoarthritis if we do imaging to look for it. I'm not advocating you do imaging to look for it. It's just it's something that we've done in a lot of research studies. If we look systemically in people that have osteoarthritis, most of them have some degree of modest increase in systemic inflammation as well. And so that may come about by virtue of the inflammation that comes from the joints, but probably more likely it comes about by virtue of what Mary was just suggesting. So for people who carry excess weight, the fatty tissue itself releases inflammatory molecules. It increases your circulating levels of inflammation. Why is that important? Well, we know that inflammation per se can increase your risk of developing osteoarthritis, not just in the joints that bear weight, but increasingly for those people who carry excess weight, who are systemically inflamed as a consequence of that. We also see that it increases their risk of hand osteoarthritis by about 20 to 30%. So inflammation plays a really important role here. And we know similarly that more recent trials, and there I'm particularly looking at a recent trial that targeted one of these inflammatory molecules called interleukin-1, and it's a trial called CANTOS, showed a 50% reduction in the number of people who are needing joint replacements who are actually on that trial. So we know that weight plays a really important role in inflammation. It plays a really important role in why you might get it and why the disease progresses. And in the very near future, we're likely to have a number of treatments that can actually specifically target that. But in the short term, do what you can. If you're above a healthy weight, try to reduce that weight. And for those people that, might think that some of this comes from your diet, don't be surprised. It probably does. And so there's a lot of interest in what we might call anti-inflammatory diets, or one way to apply that more specifically is the Mediterranean diet. So it's a diet that is rich in sort of nuts and grains and legumes, and the type of meat that you eat typically consists largely of fish, which is high in omega-3 and low in omega-6 fatty acids. So bear in mind, there's a lot that you can do. So don't ignore what you can do before all of these wonderful treatments come along.
Fantastic response. And I guess, everything links in with each other. So, the more processed, the more unhealthy the diet, I guess, the more likelihood there is of gaining weight, which increases the fatty tissue that we accumulate in the body and contributes to that inflammatory picture.
Exactly.
So it all kind of links together.
Yeah.
We have some questions in regards to PRP injections or stem cell therapies, so those more novel kind of treatments. Where do you stand with that space of treatment?
All right. So no, it's a really good question, and I shouldn't have a smirk on my face. But at present, there are no guidelines internationally that advocate for the use of PRP, which PRP stands for platelet-rich plasma, or for stem cell injections in the context of osteoarthritis. So let me just take you through a little bit of evidence so that I can support that statement. At the moment, platelet-rich plasma is a procedure whereby you would go along to your doctor, they would take a little bit of blood, they'd spin it down, they'd take the superficial layer of the blood called the platelets, and they'd re-inject that back into the knee. And it's thought to contain both growth and anti-inflammatory factors that purportedly could help with your osteoarthritis. We did a large trial of about 300 people that we published about 2 years ago, where we compared the use of 3 injections of joint injections of platelet-rich plasma compared to saltwater injections. So essentially that was our placebo in the trial. And we found no difference either in terms of pain or in terms of cartilage thickness on a person's MRI up to 12 months after we'd completed the study. So that's one of a number of different studies that suggest that when you do the trial in a rigorous way, it doesn't provide a benefit. Now, is that the end of the story? Well, it's the end of the story at the moment. Are there subgroups of people that may potentially respond to PRP or platelet-rich plasma? Potentially. And so that's another avenue of research that we're actively pursuing at the moment, but we don't have an answer to that question at the moment. But if you go along to your doctor and they advocate that you have a platelet-rich plasma injection, bear in mind that this is probably going to cost you about $500 a shot, and the current evidence base wouldn't support that practice. And most of that money goes back to the person who's administering the injection. Stem cell injections. So again, best current evidence would not advocate for this. If you went along and you wanted a stem cell injection out there in the community, you can probably get one, but it's probably going to cost you about $10,000. Typically, they're going to harvest this from your fatty tissue around your abdomen, sometimes from your bone marrow. Now, we're doing a trial on stem cells at the moment. It's called the Sculptor trial, and that is finished recruitment and will read out towards the beginning of 2026. And that's targeted towards seeing if stem cells improve both symptoms and structure. The existing evidence doesn't support that it has a role, but potentially if we do this in such a way, and I think we've designed the trial in such a way, we may see an effect. And so that's why we've done the trial. I'm optimistic that we'll find an effect. I am not advocating you go out and get stem cell injections at the moment. It's costly. The evidence doesn't support that. But hopefully in the not distant future, we'll have some evidence to dissuade my particular frame on stem cells at the moment.
So there's a lot to kind of, keep your eyes out for in terms of the research, where it's at and where it's progressing. In terms of wrapping this session up, I do want to ask, what role can consumers here play with osteoarthritis, playing actively engaging in those prevention strategies and the discussions around needing weight management or joint replacement and just general holistic assessment? I know there's a lot about therapeutic dynamics between your GP and consumers, and then what about allied health as well?
Yeah, I know it's a really important point, Mary. So, I think in general, we don't give enough kudos to our what's called allied healthcare professionals. So that's our physiotherapists, our exercise physiologists, our dietitians. And I also want to include in that frame, occupational therapists, psychologists, podiatrists, orthotists. They often do a wonderful job, and a much better job than we physicians will ever do with regards to changing people's behavior, particularly, from the viewpoint of exercise. And there I particularly like to highlight the work that physiotherapists and exercise physiologists do from the viewpoint of dietitians and nutritionists can do, because it's really easy for the old gray-haired professor to say to you, for every additional kilogram that you carry, there's 4 kilograms of load goes across your knee. If you're above a healthy weight and you lose 10% of your body weight, your symptoms should improve by 50%. So it's really easy for me to say that. For you to apply that knowledge, it's much, much more difficult. And so I know for those of you who are above a healthy weight, it's a challenge getting that weight off. And so that's where it's so important you go along and get help from an allied healthcare professional. Ideally do it with your GP or the referring person looking after you, having knowledge as it relates to that. But bear in mind that, I think more often than not, if you're going to tackle this journey, you're going to need help to do that. And coaching and prescription of appropriate advice that's tailored to you is going to be critical to that journey. So again, it's really easy for me to sit here and say, get strong, stay active, lose weight. It's another thing applying that all together. And so that joint action info website that I pointed to during my presentation has a lot of helpful resources that can hopefully help you in the right direction with regards applying some of that knowledge. Because I think, as Mary said before, um, we doctors are good at giving you the message, but helping you along that journey and coaching you through that, it's tough. And I'm not going to pretend that it's easy. So a lot of this is around changing behaviors which have been ingrained for a long, long period of time. So, getting a person to be active and to get strong and to change their diet is not easy. So kudos to you for trying it and applying that and maintaining it long term. There is no easy fix here, unfortunately.
Because I guess we had a lot of questions coming in about expectations around pain relief and when can that be achieved by either taking a supplement or engaging in exercise, achieving weight loss. And, there's a lot of expectations there. But I guess going back to what you said, it's about working with the allied health team. You have a whole multifaceted team available there to support you. And it's just having those conversations to, talk about your goals, talk about where you want to go in terms of arthritis management as well.
Yeah. So I think that, the time course response question to treatment is a really, really important one, because I think a lot of people, either get disappointed or they haven't been provided with the knowledge so they can get educated about when they should expect a response to different types of treatment. So for example, if you've got a sudden onset of pain related to what we call a flare or an episode of your osteoarthritis, oftentimes we'll advocate that you might take a short course of an oral or a topical anti-inflammatory. And usually you'd expect to see some form of response within 24 to 48 hours. So it's usually relatively abrupt and acute in terms of providing you some relief, and oftentimes a little bit shorter than that. In contrast, something like a supplement, similar to the supplements that we're trialing at the moment, it may take a few weeks of you continuing to take those supplements for you to see an effect. Similarly, if you change muscle strength, oftentimes that's not going to lead to immediate improvements in your pain. More often than not, you may not notice meaningful differences in your strength, your function, or your pain until a couple of months after you start. So don't be dissuaded after the first couple of times you've gone, you haven't noticed an immediate benefit as far as your pain's concerned. More often than not, those things do take a little bit of time.
And I guess it's like any treatment, it should ultimately be patient-centered, and then focusing more specifically on the areas that could be improved. I guess if you have muscle weakening, then targeting that could be essentially very effective for managing the disease and improving pain and those symptoms that come along with it.
Exactly. And so that's why I really tried to emphasize that point about tailoring and seeing a health professional that can appropriately assess to see, is it specifically because you're not doing the right activities, you're too sedentary? Are there specific muscle groups that are not strong enough? Are there particular activities that you're doing that are aggravating things that could be altered, or you could modify those activities so you could tolerate them better? Is it, specific ways you're carrying body weight? So all of those things need to be ideally assessed. And I should always mention, the concomitant presence here of depression, stress, anxiety, poor sleep oftentimes goes ignored, but they play a really, really important role in sensitizing and increasing your joint symptoms. So please don't ignore them. There's a lot that can be done about them. And, as Mary is suggesting, trying to make sure that that assessment is done appropriately and that your treatment is tailored according to those modifiable factors, because all of them can make a big difference to the way you and your joints feel in your journey with osteoarthritis.
Absolutely. So I will wrap it up here. And again, thank you so much, Professor Hunter, for your time here tonight and sharing that insight and expertise with everyone. We've had a lot of positive feedback coming through the comments so far. People really appreciated what you shared with them tonight, saying it's definitely had an impact on them.
My absolute pleasure, Mary. And thank you so much to everybody who's out there for listening. And please, obviously, there's a lot of links that'll come through in the slides if you didn't get them through tonight. And hopefully that information will empower you on your journey with osteoarthritis.
Absolutely. So tomorrow you will be receiving the recording link, so you can watch this presentation in your own time. If you missed over anything or you want to go through something again, you can watch it there. I'll be sending through Professor Hunter's links to his trials, where there's plenty of opportunity available for you to get involved in. So thank you, everyone. Have a lovely night. Take care. Bye. And meeting for